course, there's more on the way tonight. So
it was 34 in Fort Smith when I left this morning early. But it's supposed to be warming up. Hopefully it'll be nice when I get back, whenever I get back.
I think Faustina's going to tell us when we're going, or maybe
we got daffodils blooming in the yard. It's pretty.
We're good. We're live on Facebook now. It took a minute, sorry.
Are we opening the Zoom as well?
Yeah, the room's open.
All right. We'll let people filter in. And for those that are watching Facebook Live, welcome. And for those watching the replay, put hashtag and where you're watching from in the comments below so we can be sure to know who's in our attending tonight. So I'm Dr. Harrison. I am the clinical director for Sleep Group Solutions. If you're a client, you probably have seen me before, and I'm talking tonight with our director of education and my good friend, Rebecca Layhe. So welcome, everybody.
Welcome. So glad to see you guys. We're a week off. Jeff and I were out really teaching and had travel craziness last week. So thanks for joining us this week instead of last week. We're glad that you're here.
And I at least am home this week, and you're making.
And I am not home this week. I am in Dallas, Texas. Had the opportunity to meet with some really great teams today. Looking forward to seeing some tomorrow, and off to California after that. So always on the move, trying to help you guys learn and grow. I think Jeff's really started put together a great class for us tonight, where we're going to talk about some of the unspoken things that, as we're screening patients, it's easy to kind of go down the basic list of things that affect patients who have sleep apnea, but there are some things that are kind of nuanced as far as what we see when we're talking to patients. And we kind of want to go over some of that with you guys this evening.
Yeah, and if you're a client for Sleep Group, these slides will look familiar, but I think it's always good to remind ourselves. Sometimes we forget some of these things. And if you are seeing these in your practice, put that in the comments below too. And I think it will be a little enlightening to those that are considering getting into dental sleep medicine, but maybe just don't think they have patients in their practice. Because I think Rebecca and I will agree that there's not a dentist in the world that doesn't have the potential to implement dental sleep medicine to their practice. Now, whether they choose to do it or not, that is up to them. But back in 2015, the American Dental Association had a motion on the floor to push for all dentists to begin screening patients. And it was finally adopted as a policy statement in 2017. So now this coming up, this year will be 6 years. Kind of crazy to think about. And there's been a lot of recent changes that we can talk about as far as state dental boards that are changing their stance or their opinion because of this policy statement. So Rebecca, do you want to address the big ones in the room?
Absolutely. As far as the policies, it's our job to really screen every patient. All of the children, all of the adults need to have this screening, just like we do with patients who have, when we're screening for oral cancer. We're the closest to the airway as we're working. So it's really our job to do that now. So thankfully, North Carolina has changed its stance to really include and loop in the fact that, dentists should be able to issue home sleep testing monitors. Specifically, the ADA has said we should have some form of monitor in our office so that we can actually screen and identify with the help of board certified sleep MDs, what's going on with these patients. So signs and symptoms that we're looking for, they really want us to look for the signs and symptoms like excessive daytime sleepiness and heart disease and hypertension and snoring number one. But we're supposed to be looking for those signs and symptoms in every patient. In children, we're supposed to look for signs like growth deficiency, bedwetting, problems with attention and focus. Those, I always say, as soon as a child goes into crossbite, you've got an issue. So we're supposed to be looking for these signs and symptoms and bringing them in some form or fashion to a further more comprehensive screening for these patients, whether it be to refer them out or to take care of them ourselves. And I keep saying this, we really don't have a choice as to whether we're going to see these sleep apnea patients. We don't. They're in your chair. What we do need to make the choice about is how we're going to address these patients in our office. And the ADA really is on our, in our court to really help us with goals and guidelines to help these patients.
And then the other big one that's probably most recent, because North Carolina was last year. But Georgia was the one I thought you.
Yay for Georgia.
Now, if we can only get Virginia, that's another one.
Virginia and New Jersey. If we could get Virginia and New Jersey to open up and say, hey, you know what? Everybody's doing this. The ADA really supports it. We really need to support our dentists to do what they should be doing and do it to the best of their ability for the patient's sake. It's not about dentists. It's about patients and patient care because we're seeing these patients every day.
But I think we owe a lot to like John Comisi, Susan Miracle, Deuce Roberson, all these people in the Southeast that are
absolutely
being advocates. And really, when the American Dental Association House of Delegates met, it was after a roundtable, so a couple of years ago. The push was that you're really tying the hands of the dental practitioner that wants to do this if you don't allow them to dispense the device from their office, just in monitoring the efficacy of the appliance they've made.
Yeah.
And so, when a physician sends the patient to a sleep lab and they titrate the CPAP device and the pressures, they're on monitor. So really, to tell a dentist, you got to blindly, go in and put a device in the mouth, and then we'll test it and tell you if it worked or not. That was a very big limitation. So
taking down barriers.
But we've got to screen patients. It's the standard of care to take blood pressures on patients. Most of us are doing comprehensive dental and periodontal evaluations, and I bet every one of us does an oral cancer screening. But really, why do you screen for it? Because it's deadly. I can tell you in my 30 years, I've maybe seen a handful of patients that had an oral cancer. And so if you think that, you're going to find a cancer and save someone's life, but you don't see the dental sleep apnea patient that's in your chair, you're really missing out, because oral cancer accounts for 13,500 deaths annually. Versus OSA, is a comorbidity with a lot of other things going on.
Well, and since they gave us the job of screening for oral cancer, the rate of death from oral cancer has plummeted because dentists frontline screen for it and catch it faster than anybody before it gets to the stage where it can be treated. We're hoping we need the same thing to happen for sleep apnea. That's what we can do in our field, is really decrease the risk and rate of heart attack and stroke in patients if we'll just address this airway issue that we're looking at.
And you had mentioned screening children earlier, and that was, I think, one of the modifications that came early. At first it was like screen the adult patients, and it was screen all patients. And we don't necessarily find OSA in the children, but we find the precursor to what's probably going to be OSA down the line if we don't step in and intercept it. And it's much easier to expand a kid and, attempt to help them out in the long run. No one can claim that it is going to cure it. I think that gets people in trouble. But the consequences are severe.
And it gives us a better fighting chance.
And it's not just lifespan. I was having this conversation online with a friend that's really gotten into the whole nasal breathing and the benefits of nasal breathing. And I told him it's not about lifespan, it's about your health span, because you may live a long life, but if your last decade or 2 decades is in a nursing home and someone caring for you, that doesn't sound like high quality life to me.
No, it's about quality, not over quantity. It's a quality life as long as we can live it with the best options that we can. We have to breathe to live. We have to. And if we're taking a third of our life and struggling to breathe, what does that do to us? So, patients who struggle to breathe, we need to be aware of, we know that that congestive heart failure is such a big part of this because of all the hammering that we do to our heart all of our lives. If we're starting as a young person with sleep disordered breathing, our heart can only take so much, and it's a muscle that will break down, and we want it to last and have as many heartbeats as it can. So giving it as much oxygen, an unchallenged oxygen is its best chance to give us a really healthy life.
And I wear multiple monitors. I've got a Garmin, I've got an Oura Ring, and it's good to get those reports every morning, but you can really start to see the effects of your social choices, So this week I've made the commitment I was going to exercise, which, I lost a bunch of weight, but I didn't have exercise as part of the routine. And I was in an office in Dallas not long ago, and the nurse practitioner, she questioned my methods, and she's like, okay, so you lost the weight, but when you go back to like a normal diet program and you don't have exercise, and what do you think is going to happen? I'm like, I probably gained some of the weight back. And she was spot on. So we're back on full program. We're back on just daily exercise and motion. It's not exercising in the gym for me. I'm just never going to do that. I'm not that type of person, but put me on a mountain bike or put me on a ski slope and I'll do it all day long. Or I know you and I, we go for walks around the hotels when we get a chance to be together.
Yeah. I got my bicycle. I'm pumped up my bicycle tires, and I got it's an e-bike.
You brought up cardiovascular consequences, and we're going to get to that a little bit later on, but even like the impact of alcohol on robbing someone of deep sleep. And then when you rob them of the deep sleep, the heart rate variability stays really minimal. So the heart's just constantly working and it doesn't get that rest recovery period. So
every muscle has to rest. And
I think you'll agree, dentists are probably seeing these patients more often than the patients are seeing the physicians. And so these are all good reasons for why every practice should be screening for sleep-related breathing disorders. Perfect. This is the slide. I didn't even know it was there. The risk factors. So we're coming off of what Matthew Walker calls, I have to put my glasses on to read his exact words because I don't want to do him disjustice, but Why We Sleep. Excellent book if you've not read it.
And it needs to be on everyone's reading list. If you haven't read his book, everybody needs to put that on the reading list.
It came out a few years ago, and if I can just read a snippet from here, it says, I believe the global experiment, which involves 1.5 billion people who are forced to reduce their sleep time by 1 hour or less for a single night each year, and it's very likely you've been part of this experiment. Well, we're just coming off of what's known as daylight savings time. And so for most of our states, now it's always weird why Indiana doesn't do it. I can kind of get Arizona, but the springing forward, what it leads to, and he doesn't cite the exact figure in this book, but I remember hearing it on a podcast. He would say the day after springing forward, they've looked at millions of hospital records and found a significant spike in heart attacks.
Yep, heart attacks.
And then conversely, they find the same drop in the fall when we move the clocks back an hour. So to me, that was always interesting. Now in the podcast, I remember, I think it was The Drive with Peter Attia. He's a physician, or might have been the Joe Rogan one. I believe he said 25% increase, which was significant.
That's significant for an hour. And in the same context, that hour of sleep, we ask our young people to get up for school and go during their most critical time of sleep, and wonder what we're doing to our kids. We really need to consider, a better start time for kids as well. That children need to sleep more than we're allowing them to sleep. We need to do a better job letting kids sleep longer and getting the best rest that they can for their brain and their body. And
the last point he makes in this paragraph on this point, and I had forgotten this one, it was a similar rise-fall relationship is seen in the number of traffic accidents on daylight savings and falling back.
It makes sense.
Proving that the brain, by way of attention lapses and microsleeps, is just as sensitive as the heart to a very small perturbations. Can't even say the word. of sleep. So change in sleep.
Wow.
So, great book. And I think there's 1,500 factoids in that book.
Yeah, everybody needs to read that book. That's so insightful and great information for everybody.
Last weekend, I got to listen to my friend Dr. Who, Jerry, was lecturing in North Carolina for their AGD. And the way he did this slide, and maybe we all do it, I think I did it a little bit different, but I like the way he said it. It's like, if you're breathing, you get a score of a 1. If you're overweight and have hypertension, that's almost a 16 risk factor that increases to that. So if you're a smoker and you're overweight, that's only an 18. So you have to combine 2 of those things, and you're still always short of the increase of risk for a heart attack or stroke when you have OSA at 23 times the risk. And then I believe if you add them all up, you're almost at the 50-50.
Yep.
So again, comes back to those social choices.
Sure.
This is the slide I always tell, I know you do the same thing, is like dog ear this one, print it, laminate it, have it in every operatory to talk to your patients, because I think it's a key. And that's from, National Institute of Health. So very good slide. Why don't you take this one? I hear you do that all the time.
Well, when we talk about how many people have sleep apnea, this is an endemic, not a pandemic, endemic epidemic of undiagnosed sleep apnea. We've got, if you're over 40, almost half of us snore, and snoring by itself has health risks. So one of the unspoken things is about snoring. We think of a person who snores as a person who doesn't necessarily need treatment until they get to the point where the snoring is causing arousals at about 5 times an hour. We kind of, on occasion, just ignore this noise until it's actually doing something to you that's diagnosable. Snoring is a diagnosis, and snoring by itself is linked to increased incidence of AFib. Snoring matters. So if we're looking at about 40% of Americans plus who snore, we've got to take care of those patients to start with. That is something that's not talked about enough, is snoring matters. 1 out of 4 of those adults have some form of actual obstructive sleep apnea. So when we look at the whole pie, we're talking about 87 million plus Americans have obstructive sleep apnea or some form of sleep disordered breathing. And only 1 out of 10 of them have ever been lucky enough for a doctor to say anything to them about it. And if you've been lucky enough for your doctor to say something to you about it and you actually get a sleep study done, only 1 in 4 of those patients are actually adequately treated. So talk about a mountain of patients ahead of us that still need care, who are either undiagnosed or diagnosed and not really getting the proper treatment. So we've got a lot of patients to see, and we need to start with those patients that snore and treat those patients that snore. Now, does your insurance pay for it if you snore? No. Do I care? No.
Would your doctor treat it if they diagnosed it as
no?
What are they supposed to do according to
treat it? Because their own practice parameters say that they should be referring these patients with primary snoring to a dentist for care.
I can count on one hand the number of patients referred to me for
primary snoring, and it's just, I think it's criminal, because what does AFib cause? So snoring is linked to increased incidence of AFib. AFib causes stroke. I would rather not have stroke. I would rather have like a massive heart attack, take me out and just let it be done. I'm good. I can handle that in my brain, kind of, sort of, not really. But the terror of stroke for me is almost paralyzing.
I mean, it leads
my ability to speak or swallow, or getting a field cut, not being able to see, or lose, and having to have someone take care of me or feed. Oh my gosh, that's horrifying. So please, don't ignore the snore. It matters. Snoring matters. That's our first unspoken thing we just don't talk about enough. that it's
And
not.
I didn't see I see chat and Q&A, but I'm afraid I'm sharing my screen. So I think if I pop on that, I might put them on top of stuff. So we'll address those at the end.
Yeah, we won't
We
miss
don't
you.
have a big presentation tonight, but
Yeah,
just to let you know, if you're putting something down there, I will get to it. So be patient. Oh, the good old Epworth. It's a necessary evil. It's a validated screening tool, but it's so subjective, so subjective.
it's my eye roll one. We have to have it. It's one of those that I say insurance companies have latched on to because it's a great way to put a
You're
stop.
not tired enough.
Yeah. But if a patient's mild or stage 1 sleep apnea, which I prefer to call it, if they're not sick enough, sometimes insurances balk. They want them to be sicker than just stage 1 sleep apnea. Stupidest thing I've ever heard of in my life. So this is just our way of helping them understand this patient has excessive daytime sleepiness. This is what qualifies excessive daytime sleepiness. So make sure that you're doing a good job with this with your patients. Don't let them just zero everything out because they don't have time to do it. This needs to be done with intention and with thought because it matters for patients who have stage 1 sleep apnea.
And I think a lot of people that get into this just think they can hand a form to the patient and expect to get the right answers. And
yeah,
I teach when people do this, don't hand them a form. You've got to put them first in a context of, think of the most tired you've ever been, and let's answer the questions when it's appropriate as if that's how you felt.
Right. So I'm gonna answer them like right now because I've been up all day and all morning, and I am good.
The other little nuance that I like to throw in is I changed the word fall asleep to would you doze off?
Yeah. Would you doze off?
And oftentimes I'll see it in the classes like, oh yeah, it does sound different because if you said, would you fall asleep, as a passenger in the car, maybe, but would you fall asleep driving the car and stopped in traffic? No, but you might doze off. And so I think just
those
a
eyes,
little
yeah,
bit of swing in the vocabulary helps people out.
it's
So.
important.
But the magic number is 11. Of course, I believe it's totally unethical to tell the patient before they've filled it out that you better score an 11 or, might as well rip this up. And it's also kind of a little questionable to hand it back to them and say, do you want to change your answers after the fact? But
I think that asking them to answer them with intention is an important thing. That this is an important screener. Please consider these questions carefully as though you're at your most tired part of the day.
And then I really think it just leads in perfectly to signs and symptoms that red flag that the patient needs their sleep tested.
Mm-hmm.
Because stop bang is not diagnostic, but it's certainly suggestive and puts the need for the sleep test out there. And it always blows my mind on how many people that are claiming to do dental sleep medicine still can't recite these back like the back of their hands. But asking a patient if they are aware they make noise or do they snore while they sleep. Has anyone ever told them that they snore? Or the more polite way I like to do it that turns one patient into two is, are you aware of anyone who snores? Because they can say, yeah, my wife or my husband or my girlfriend, my boyfriend, or my mom or my dad. But they'll also sometimes say myself. But if you just come out and accuse them of snoring, they get really defensive. So I try to be a little delicate with that one. As far as tired, the way I like to ask this one is, if you could take a nap most days, would that be a welcome thing? Do you feel so tired that, a nap would be welcome at whatever time during the day, if you had the chance to? The observed, I've always had the most trouble getting a patient to respond to because they're asleep. So, has anyone ever observed? Well, I sleep alone. So no. I'm like, okay, let's try to figure out other ways. Do you have any tricks for the observed?
I just, this is when bed partner questionnaires are so important to me, or having a bed partner around. Has your wife ever told you that or has your husband ever said that you choke when you're sleeping or gasp when you're sleeping? Have they ever said anything about, do they elbow you in the middle of the night and wake you up? Is because you're not breathing?
That reminds me though, I have asked when they say they sleep by themselves, I'm like, well, have you ever woken up suddenly, like with a jolt?
Yeah.
Or a
Startled.
jolt?
Yeah. That's a great way. That's a super way to ask that question. Because, you know, as somebody who does sleep alone, that was one of my biggest triggers, is that I would wake up with this snort, you know, that wake myself up because I snorted, and I would have really like pounding, like anxiety heart, boom, 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 heart rate. That was my, I got a problem. That was important to me, but you know, there's nobody to tell me that that's happening, but I'm sure that is because I stopped breathing and I have bad sleep apnea.
And then for the P, it's the blood pressure. I always remind doctors and dental teams that are getting into this is you may be taking the blood pressure and it's registering normal, but look at the health history and look at their
And
list.
that's on you should know what by their medication list, whether they've got hypertension or not.
I mean, that's the easiest.
They're medicated for it. They have hypertension.
I like to coach offices to have a morning huddle, and everyone should be bringing one name of someone they're going to see in the day that they already suspect has a problem. So kind of preempting your day and knowing where opportunities are, because the industry is going to happen. It's going to get busy, and patients are coming there for a dental appointment and not in the mindset of airway health.
Truth.
But it's got to be picked up on in the appointment. And if time allows, or the patient can, or we schedule them to come back, however it works in your practice.
Right. Every day before the next day's patients, and in the evening, everyone should take time to look at their schedule to be prepared for the patients for the next day. Some people don't like to look at the next day. They don't want to know what's coming. They just want to hit them in the face. But before patients hit the door, we need to take a few minutes and look at what's coming in the door, so that we can have, so that if the whole tornado does happen and we just have a day fall apart, we still have at least one or two gold patients that we're not going to miss. If nothing else, don't miss this patient's airway, because this is we want to make sure that this patient gets screened because they show these signs. I looked for them.
And I know we both agree that once you're at 3 of these, it's go time, sleep study. It needs to happen. So the backside of BANG is the body mass index. Again,
chubby. That's chubby. 28 is chubby. 30 is obese. 28 is chubby. So are they chubby? That's easy.
And I think you and I both have to check the A here. I'm sorry, but I'm a few years past it now. So. And then I did hear a sleep physician say last year that the neck size was more important to him than the BMI. And that's mainly because you can put the weight on in the hips and it has nothing to do with airway. But if your neck is large, all of that fat is up around the neck.
Absolutely. That's the reason why women tend to have a later onset of obstructive sleep apnea. Reason number one, hormonal changes. But reason number two is when we're younger, we carry more weight in our hips and in our below our waist, and after menopause we tend to lift that lifts into our chest and into our neck as we mature. So you can have really skinny legs, but you can have a double chin.
And here's a good one. You come in the morning huddle and you got an old fat guy coming in your schedule. You've already got a name. You don't even have to read anything. So men more than women, but as decades go on, it starts to level off. And then the ninth one that I would include, although it's not an official one, is if you're aware that they clench or grind their teeth. They may not be, but if you've made them a night guard, if you're looking at the dentition and you see wear patterns, cracked teeth. I even heard someone say, well, the absence of a tooth, aside from maybe trauma, is kind of a cardinal sign for obstructive sleep apnea. But think about, here's one of the unspokens, the failed implants. The surgery was done fine. They can't figure out why it's failing. It has to come out. The perio patient that doesn't have anything in their mouth to indicate why they have periodontal disease, but yet they don't respond favorably to scaling a root planing or surgery, or they're just a difficult patient.
Don't clean up. Do 4 quads at a nice fine scale, and they just never clean up because they have such high levels of inflammation.
Yeah, it's inflammation. It's all about inflammation. And we know with nasal breathing, we'll get a decrease in inflammation. But with mouth breathing, it's going to be a chronic fire that's burning in people. So more and more things pointing to that. I love that you brought up Bedpartner History, because if I'm doing a sleep consult, I want them to bring Bedpartner, because the answers will change. The stories will become different. It'll become super important to one of the two, if not both of them, that they get treated. And oftentimes you turn that single patient into two patients, especially once you have a successful result. I just had a guy not long ago, he says, I just saw the 26th family member from someone that I met at a church barbecue, because they ran up and said, you saved my marriage. And he was like, what?
Wow.
He's like, you stopped my husband from snoring and you saved my marriage. And now you've helped me and you've helped. And so like this family reunion is where they were telling the story. Later on, it led to so many outside the practice referrals for them. So
Wow, that's
kind of a crazy thing.
Bed partners matter.
And then I just had a recent article that came across my desk. And if anyone's interested in getting articles, put your name and contact in the chat. I'll be glad to add you to my list. But they had done a recent study and they found that 50% of polysomnograms that OSA was the diagnosis were also exhibiting bruxism. And it's been one of those kind of controversial topics before. There's other causes to bruxism other than OSA, but some sleep monitors can pick up on it. We certainly are looking at it in an in-lab test, but patients don't start at the lab test for sleep anymore. It has to be done at home, mainly because of insurance demands, and we can pick up on OSA at home. It's the kind of the more paradoxical things that need further testing, or if they suspect centrals or lots of other, or they don't have any time on the back. I heard a sleep physician tell me that once too, is they wanted 2 hours of reported sleep on the back in order to make their diagnosis. So just was their opinion on it. But if you're looking in the airway and you can't see the throat, here's your sign. Bill Engvall right there. I'm the Mallampati class 1. I was a child of the 70s, and at age 5, I had my tonsils and adenoids taken out, and I'm a Mallampati 1, but I will admit I have moderate sleep apnea, especially when I was heavier. So don't put all your emphasis in any one sign and symptom, I guess would be my caution here. If you're a 3 or 4, you can pretty much guarantee. I always like the picture on this one too, is like, what a narrow maxilla.
Yeah.
The lips open, the mouth's open, but I never really wow. I couldn't get a cotton roll between those first molars in the upper arch.
No. And so, when we're looking in the mouth like this and we're doing a Mallampati, other things that we see as we're going like this, sometimes we don't talk about it too much, is like tori. Tori lifts that tongue up and gets it out of the floor of the mouth too, and it'll raise it and raise the Mallampati as well. And it's tori, sometimes is linked with bruxism, and it's just something we don't talk about a lot, and it kind of goes around and comes around.
And you could make the argument that crowded teeth. And we always see it, usually the lower anteriors. So I get to hang out with some really cool people with Airway Health, but when the maxilla is underdeveloped, the mandible is going to follow it in most cases. So we'll end up with a trapped mandible. And Ben Moralia says, the maxilla is the criminal, the mandible is the victim. And then Kevin Boyd will say, we can expand the maxilla and the mandible will follow it until it doesn't. Like, I love that one too. It's like, well, when is it not going to? Well, you got to keep watching it. So we have to think of the mouth as a 3-sided box. We're going to have teeth in the front, left, and the right. So when it's a small box and you've got this huge tongue, or even a normal sized tongue in a small box is going to appear huge. It's only got one place to go, and that's backwards, unless the mouth pops open, then it can come forward.
Right. And that's what we don't want you to do, is pop your mouth open.
I was having this talk last week in North Carolina too. It's like, if you start increasing the vertical, you can't get the lips together. I'm like, I don't care, because if there's a space in the appliance, then their tongue can come forward. And now I've got the patent.
Everything I want.
I've got the appliance, I've got the lips where they can go, and I got the tongue in the hole. So that's going to open the airway. And they're like, oh, I never thought about that. Oh, good old turkey waddle. This is the one you can sit in the airport and just start picking people apart. Oh, you're feeling your neck.
Yeah. Yeah, now that I've lost weight, I like have, yeah.
Extra skin.
Yeah, it's got to tighten itself back up. But
But
yeah, but
when
you know,
there's under
it's
when
a
there's
sign.
under an inch in that cricomenal space, and then you throw in a tonsillar grade from the sides, which is known as Samsung classification, a 2 or greater, and you have an overbite. So you've got a trapped lower jaw. When all three are present, a 95% predictive value, and that's from New England Journal of Medicine. So kindly a peer-reviewed publication there. And all the way back to what, 21 years ago, 2002?
Yeah. So, you know, in layman's terms, it would be a deep bite, a double chin, and big tonsils. Tonsils you can see with deep bite and a double chin. And you've got a 95% predictive value.
Crazy, crazy, crazy.
I think that's one of the screeners that doesn't, you know, as far as signs and symptoms, it doesn't get used as much as it should. And that's to me, one of the easiest screeners. So one of the easiest signs and symptoms that we see, because that's so black and white.
And I think every dentist is
Class 2, you got a double chin and you got tonsils I can see, you're good. You're out of here with a sleep study.
Everyone would see this picture and they'll call it macroglossia, but I would almost argue it's, you know, micro jaw.
Yeah.
I think it's probably a normal sized tongue that's trapped. There's a book called 6 Foot Tiger in a 3 Foot Cage. You maybe read that one?
Yep, it's a good book. I call it a 2-car tongue in a 1-car garage.
And this one's actually kind of trying to fold up on itself to fit
Yeah.
in.
Yeah, I tell people your tongue's not supposed to have to fold in the middle to fit mouth. That's another sign we don't talk about much, is that clefted tongue where you've got your tongue folded just to get down into the mandible.
Or the white coating on the top of the tongue every morning that scrapes off real easy. Now that's just extra protective skin basically that's forming on the top of your tongue because of mouth breathing.
Yeah,
often associated with halitosis. So, you know, you want to throw in bad breath into one of the unspoken signs and symptoms.
That especially young people with that sour breath smell, or kids, you know, I remember my mom asking me one time, do you feel okay? Is your stomach upset? Because I had a real sour kind of breath when I was younger. And it was mouth breathing. It was because I was developing sleep apnea, you know, in my youth and having trouble breathing and sleeping, breathing through my mouth. And, you know, that is something we don't talk about a lot either. So that sour kind of, you'll know what I'm talking about when you smell it now. You can't.
I can smell it and I don't even have to smell it. It's one of those.
Yeah, it's not a perio breath. It's sour.
And then scalloped tongue. So, you know, a few years ago, everyone at Sleep Group was encouraged to like take a picture of their tongue and post it. I'm like, I think it's dangerous because you can have a non-scalloped tongue and still have OSA. I'm one of those people. I've got a very large jaw. We see it. And I think the thing that's often overlooked in this picture is look at the wear on the teeth.
Yeah, it's the Brooks facets on his teeth that are
But that enamel doesn't just go away. I mean, that's an acid reflux. That's a subsequent attrition and wear. So there's a lot going on in this picture.
Yep.
The cupped out cuss tips, you know, they're not in occlusion. So how do they get these erosive lesions in there?
Yeah. So, you know, when we're talking about acid reflux too, that's another thing we see in our medication lists. If we do a better job really paying attention to med lists on patients, we find a lot of hidden signs in there because patients take Nexium or Prilosec every day. That's not normal. That's not supposed to happen. It's not how that's supposed to be prescribed. That's a hidden sign that we got something different to look at.
And then the classic red throat, you know, you're looking back there, and if the patient's not claiming they have a sore throat, this is telltale snoring that's happening. The elongated uvula, redness in the soft palate and the tonsillar pillars, classic signs and symptoms of snoring or worse. You know, it could be more than that. Just don't know. Looking. This is a new video. We're going to see if it plays. The first time we had it was back in January, and I don't recall it playing in the class, but we did it in February and it played. So the cryptic tonsils always gets everybody kind of grossed out because this always falls like right before lunchtime. So let's see if the video plays. This is Dr. Andrew Ely's video, I believe.
Yeah.
Okay, go ahead and say out.
That is one long eagle. It's like an extra tongue.
Oh, I can't, I just, where's that patient breathing? That, I mean,
How are they not choking?
if you can't see their uvula with their mouth open and you can't see their uvula, where is it? It's in their airway. It's down below where it's supposed to be. Oh,
But again, I look at the mandible. So how many gold crowns are in there? You got a tongue that's the shape of a heart now. You've got no visible airway in the back of the throat.
and that tongue is not scalloped.
Not scalloped. Good point. So when you're seeing these things in your clinical exam, what it leads to in a Sleep Group Solutions client's office is put them on the echo vision. So not only are we going to measure the oral pharynx with our pharyngometer, but before you tell a patient to tape their lips together and try to improve nasal breathing habits, is measure with the rhinometer the nasal passages. Because the last thing I would want to do is tell someone to tape their mouth shut if I haven't properly evaluated the nose.
They can't breathe through the nose. That's kind of not a good thing.
So this is what we're known for those who aren't clients that are on the webinar. I'll let you walk them through because I know you do this part so well, Rebecca.
Well, one of the things that pharyngometry lets us see is where the airway is collapsible. We have, as those of us who have sleep apnea, have airways that are very much like fireman's hoses, but they can collapse in more than one place. So pharyngometry lets us see from the incisors through the oropharyngeal junction down the airway. So the most common area for collapse in patients is in that oropharyngeal junction, or in the lateral wall of the oropharynx, where the tongue, the base of the tongue, and all that heavy musculature lies.
My cursor coming up on your screen.
Yeah, I can see your pointer.
Yeah.
But the airway can collapse all the way down to the, past the glottis. We're protected by bone above the oropharyngeal junction in the hard palate. We're protected by bone at the hyoid and below, but all that area between the oropharyngeal junction and your cricoid cartilage is unprotected. It's just a tissue tube surrounded by tissue. And if it's healthy, it'll stay open in your sleep. It has enough integrity in the walls, but for those of us who have sleep apnea, you've got this collapsible airway that really has to have some kind of support, either from the outside musculature or airway or air movement. So pharyngometry lets us see it live in real time, where that airway collapses and how much it collapses, so that we can actually see if we can fix that collapse by repositioning your mandible and employing the muscles for you.
Reminded me of a lecture a sleep physician gave about 1 year ago, and he said the most definitive treatment for obstructive sleep apnea, tracheotomy.
Absolutely, just bypass all of it. There's a patient that I helped who was a bariatric patient, was 600 plus pounds. And he had sleep apnea all the time. I mean, he had it daytime and nighttime. He could not oxygenate. So they trached him. And within a year, he was down about 230, 240 pounds just because he could breathe. Still what, I mean, he's over 600 pounds. He's not, running a marathon. He's just breathing and able to sleep and breathe. And he rapidly dropped weight because his body started to settle. And that was so exciting. But, that's what breathing does. If you have to bypass it all, you have to bypass it all. He'll get a revision and he'll go back, as soon as he gets his weight off, and he'll be on a CPAP or an oral device, and he'll live a much longer life and reduce his risk. But man, That was really illustrating of how much oxygen does for you. Just breathe.
Here's an example of rhinometry. I
Yep.
see every time is getting closer, so I want to
Oh,
make
good.
sure
Talk it up.
the tips here. If you're using rhinometry and you've been using it for a long time, you may have heard that it's 10% of the test and 90% is pharyngometry. And I'm seeing a growing trend in more people using rhinometry, especially in the orthotropic camps. So if you're expanding a patient, if you're utilizing some form of myofunctional therapy, whether it be an actual myofunctional therapist session, or whether it be some type of habit corrective appliance, or you're doing expansion, this is a very quick, I mean, it takes less than a minute to do both sides to check your progress on, is this patient really developing proper breathing habits? And so we measure left and right side independently. On the new software, it's easy to copy an old appointment forward so you can see how they're progressing, previous appointment to the next. If you're, it's coming into springtime, so we're dealing with seasonal allergies. I know in North Carolina, everything was in bloom. And so my nose fired up when I measured myself as a demonstration. I was like, oh, that's different.
That's bad.
Versus Colorado thin air here where nothing's growing right now. But certainly we're seeing more and more. And things to watch out for is, making sure you get a seal, because a poor seal will raise that measurement. Making sure you're not distorting the nostril so you get an inaccurate reading of what the actual cross-sectional area is. So just tips and tricks. And the other thing I will usually say to someone that's new is seat it like you're seating an alginate impression. Go from the back to the front versus, assistants just like to stab people, I think, from the front with the rhinometer. So things to watch out for. And now as we move into pharyngometry, so that's normal rhinometry. That would be an obstruction. If we see crisscross lines, it's the deviated septum. If you've got cone beam technology in your practice, now you've got some more clues and data points where you can know where you're going in that data volume versus looking at this massive field of view image. So just to relate the two. And then as we move into pharyngometry, this is going to take you a few more minutes. There's a few more measurements we can do, but in an airway screening, and I like how you call it, it's the daytime airway. And then the collapse test would be a representation of your nighttime airway, or a simulation of the potential of what's happening to your nighttime airway. It's probably actually worse.
It is worse at night. Yeah.
When you see a drop, that is when, and I've got several client testimonials, the patient's eyes just pop. It's like, whoa, I didn't know I collapsed that bad. Maybe I will do the sleep study just to figure out, maybe you're not just trying to sell me some type of device here. So I do believe case acceptance is higher. I think there's just so many applications for pharyngometer that people discount. We're known for, you find the optimal jaw position, but it's really begins much earlier. It's in the screening and getting the patient to the diagnosis. If you haven't got that far, it doesn't matter where you know where to put the jaw. And then checking the fabrication of the device, and then checking the ongoing appointments with the patient as they age and as they either gain weight, lose weight, just to make sure you're still dialed in to the right position. We did an efficacy study in North Carolina, and that was kind of interesting. As while he had reduced 50%, he was still in the moderate category. So instead of, since the rules just changed in North Carolina, it's like, well, why don't we try to dial you in a little bit better now that we can dispense the sleep studies from here before we turn you back over to the physician and claim, hey, we've done the best we can do and achieved our maximum medical improvement. So that was interesting. And it was on the president of the Dental Association. So
good.
Huge. But it's that separation. So for those that don't know, from left to right, we're measuring distance. From bottom to top, we're measuring size. So in this picture, the green line is higher all the way across until we get down to about 19.5 centimeters. And that's where they kind of are the same. So the green area, which is the breathing airway, is larger. And then when we simulate what a reduction in airflow would do to the size of the airway, it gets much smaller. And the data points, I always make it easy. I know Jerry was like all about his decimal points, but I think it gets too confusing. It's 3, 2, 1. An average airway when they're breathing should be around 3 square centimeters. A collapse that goes below 2 indicates there's a high risk for, a sleep-related breathing disorder, needs testing. And then if you can reposition the jaw and improve that minimum by 1, you've got a very high chance of success. So left of the blue line is your oral cavity. If you went to orthotropics, you'll be watching the vault of the palate over there. Then you got the OPJ, oral pharyngeal junction, like Rebecca was talking about. Oral pharynx to the left. People that have their minimum there, they're usually the ones, in my opinion, that need the vertical. The ones that collapse later down in hypopharynx, they're the ones that typically need the advancement. And if you see a flat line kind of from start to finish or somewhere in the middle, those are the ones that need that magic combination. And I cannot think of another way to find this information without wasting a lot of chair time. It doesn't mean I'm always going to start there, but I at least know where I'm going. And then I can set some reasonable expectations with the patient on what to expect and how many visits it's going to take to get them dialed in. But a lot of people, it doesn't take much advancement. And I think that's one of the myths that is out there because of the way dental sleep medicine is taught throughout our country. So we have these jigs from Airway Metrics, and Bob Porchover just recently passed. He was the inventor of those. So that's sad. And these have evolved over time. Oh, I've got good news too, Rebecca. I talked to Kattenbach, who holds the patent on these. They're going to change the packaging. No more 1980s.
Praise the Lord. I've dropped those things so many times. I love it.
That's what I was talking about.
Because they don't make CDs anymore and the CD cases aren't available. I'm just saying.
Probably it's a supply limitation. But here's what we were talking about earlier. When you've got the collapse test and you change the vertical and you change the advancement, and you can improve that airway by 1 square centimeter or more, it's going to be a slam dunk. As soon as you get into that position, you're going to have a good test. And that's backed by sleep physician, Dr. Malhotra, who is out in San Diego. So, hey, you're going to San Diego, you can stop by and say hello.
Yeah.
And Dr. Baum pointed this out to me the other day. He says, Malhotra says the subject is 35 times less likely to have OSA when you increase that minimal cross-section area by 1 square centimeter. And I think I've always said that, but I didn't realize where it came from. I had seen it clinically, but now I have my validation. So I'm going to look into questions and answers. We've got just a few minutes here, but coming up, if you've never been to a seminar and you're interested in learning more, we've got Chicago right around the corner, Houston.
I'll be there.
April. I'll be in Boston in May. I think you're coming with me.
Yeah. I go to Boston. We've got some great opportunities all over the country to learn more, spend some time with us, let us help you. We're invested in really helping teams become successful. I know Jeff and I both spend a lot of time answering phone calls and answering text messages and traveling to help people. If this is something you want to do, and you can make one of these seminars, fantastic. I would love to see you. If your travel is not something that you can do and you really want to learn how to do this, if you'll reach out to either Jeff or myself, we'll be glad to help you in your office. We can, bring some education to you. Just need to visit with us. Let us know how we can help you and your teams be more confident, screen your patients, help more patients. We're here to do that for you.
And the question that came in was, what was the name of the book that I referenced? It's Why We Sleep. It's by Matthew Walker, who is a PhD at UC Berkeley now. I believe when he wrote the book, he might have still been at Harvard. So he's got a little bit of credibility behind him.
Yeah, it's a great.
He's all over YouTube. If you don't like to read and you just want to watch an interview, he has a TED Talk that's probably one of the most downloaded TED Talks. And then we got a lot of friends that are signing in. So hello from Las Vegas. Hello from
Hi, everybody.
Hello from El Paso. So thanks for putting that down there. It's, when we talk to each other, it's like me and Rebecca talking. We wonder if anybody's listening. So
yeah, thanks for being with us this evening. And it's always good to see names and faces, and we don't see faces, but names that we know, and glad that you're here. Let us know how we can help you.
All right, guys. Thanks for joining us. Rebecca, go get some sleep.
Yeah, it's time to sleep.
Night, everybody.
Good night, everybody. Thank you.